Good afternoon. My name is Clayton Travis. I'm the Mental Health Policy Fellow with Texans Care. We're going to be going over some mental health coverage and access bills, which include bills related to Medicaid managed care, Medicaid expansion, and finally insurance regulation. So with that, we'll jump right in. First off, we have HB 1023 by Burkett, creates a task force to investigate and make recommendations concerning the mental health workforce shortage in the state. The mental health workforce shortage in the state has been well documented, and one statistic notes only 5 child psychiatrists in all of rural Texas, so this is an issue that definitely needs to be looked at. HB 2625 would expand the priority diagnoses in which local mental health authorities must provide services to. Currently, only the big 3, major depressive disorder, schizophrenia, and bipolar disorder, are provided services, and this bill would expand those diagnoses to a number of other mental health disorders. HB 473 is a psychotropic medication bill that is kind of a hot topic this session. This bill is a little different as it applies to all kids in Medicaid instead of just those in the foster care system. It requires a pre-authorization for any psychotropic medication for a child under 5 in the Medicaid program. HB 2129 would require clients of the Department of State Health Services, or DSHs, including children seeking mental health services, to fill out an attestation form that they do not have access to other health coverage. This bill is in preparation for the individual mandate as required under the Affordable Care Act that requires everyone to have health insurance. The idea is that client services at DSHs may decrease with the increase in health coverage. The Senate version of this bill, SB 1057, is actually up for a hearing next week. SB 718 is a bill that is a part of the Mental Health Code rewrite. The Mental Health Code rewrite is a statewide stakeholder effort by Texas Appleseed. It clarifies in statute the ability for a 16-year-old to consent to his or her own inpatient and outpatient services, when before it only mentioned inpatient. Additionally, the bill requires a court order, emergency detention, or an order of protective custody for anyone younger than 18 who is in the custody of the state to be admitted to inpatient or outpatient mental health treatment without their consent. Next, we're going to move into some Medicaid managed care bills. First, we have SB 58 by Senator Nelson. This bill essentially carves in, under a managed care financing structure, case management and psychiatric rehabilitation services for those with serious mental illness, including kids with serious emotional disturbances. Currently, these services are paid for on a fee-for-service basis out of DSHs. The bill has moved out of Senate Health and Human Services and now is waiting to be heard in calendars. SB 337 by Rodriguez is a refile from last session that requires MCOs to coordinate the care of individuals receiving services through both the MCO, or Managed Care Organization, and the LMHA, Local Mental Health Authority. HB 1032 would require a single 2-page form for all prescription drug pre-authorization requests. This is an effort basically to just streamline the process so we can get those who need certain medications, those medications more efficiently. HB 624 disallows managed care organizations from paying different amounts to different professionals who all provide the same type of service. HB 3452 by Island gives a provider the right to a hearing to dispute the amount of a Medicaid reimbursement rate if it is considered too low to recover a provider's operating expenses or allow for a reasonable return on investment to ensure the provider's financial integrity. HB 2731 by Raymond lays out a bunch of requirements for managed care organizations to reduce the administrative burden on providers. This includes efficiencies in submitting and tracking pre-authorization requests, standardizing application and credentialing processes, and educating providers on proper submission for clean claims and appeals. HB 1088 attempts to address some of the issues reported from the managed care rollout in South Texas, specifically around reimbursement rates. The bill itself would provide a history of reimbursement rate reductions, which is to inform the quality of the contract that the managed care organization may or may not have. It doesn't allow any managed care organization to reduce reimbursement rates during the first year of a contract, and it provides enrollees with notice of reimbursement rate and covered service reductions. HB 1089 doesn't allow a managed care organization to refuse to reimburse a network pharmacy provider for dispensing a medically necessary medication prescribed to an enrolled physician on behalf of a Medicaid client. Next, we're going to jump into Medicaid expansion. There's been 20-plus bills filed on Medicaid expansion this session. Both sides of the aisle, both Republicans and Democrats, have filed bills, which makes for a robust conversation on the topic. First, we have SJR 8 by Senator Ellis, which is a constitutional amendment to expand the Medicaid program. There's an equivalent on the House side by Representative Coleman. Next, we have HB 593 by Neistat, which is a standard statutory expansion. There were several accompanying bills to that one as well. And on the last day of session, we had HB 3376 filed by Turner, along with 5 other Democrats, which is a statutory expansion of Medicaid. It also includes permission to gain permission from the Department of Health and Human Services or the Center for Medicaid and Medicare Services at the federal level for cost-sharing provisions within the new Medicaid population. The next 2 bills are bills filed by Republicans. HB 3791 by Zerwas gives permission to the Health and Human Services Commission, or HHC, to negotiate with the feds to craft a quote-unquote Texas solution to Medicaid expansion. This should include leveraging private markets, cost-sharing, and medical utilization in low-cost settings. It also grants permission to HHSC to negotiate a block grant with the feds. However, it's important to note that these 2 negotiations aren't necessarily tied together and can be negotiated separately. Senator Dewell's bill, SB 1477, is basically a block grant permission bill. So finally, moving on to insurance regulation. Actually, I'm going to make one more note about Medicaid expansion. There is a committee substitute rider within Senate Bill 1, which was approved yesterday, that lays out elements that should be discussed in a Medicaid expansion negotiation. So that's something to keep in mind as well. All right, moving on to insurance regulation. We have HB 459 by Guillen. It gives the Texas Department of Insurance, or TDI, the authority to provide oversight on health coverage enrollment navigators. These are the individuals that are assigned within the ACA to help people get enrolled in health coverage come 2014. If federal oversight is deemed not comprehensive enough, this gives the Texas Department of Insurance the authority to provide additional oversight as we deem it necessary. HB 3326 by Coleman would expand the mental health disorders that health benefit plans must cover from a select amount of disorders to any disorder that would impair a person's functioning in their community, school, family, employment, or social group. HB 592 by Neistat would include post-traumatic stress disorder as a type of serious mental illness for all purposes. HB 3226 by Coleman requires health coverage of a self-inflicted injury from birth to age 18 in an attempt to commit suicide regardless of the mental health of the enrollee or if the injury results in the death of the enrollee. We've seen some insurance companies not wanting to pay for the injuries of certain individuals and children based on the fact that the injury occurred during a mental health crisis. HB 2853 by Turner is basically an all-encompassing TDI, or Texas Department of Insurance, rate review and filing bill. It requires health benefit plans to notify any entity responsible for paying premium of rate increases. It requires a report to the legislator on a plan's market share, profits and losses, medical loss ratio, and rate filings. And furthermore, it defines what an excessive and an inadequate rate is, and gives authority to the Texas Department of Insurance Commissioner to deny certain rates that he deems excessive, he or she deems excessive. It also gives permission to the Public Insurance Council to review those rate filings. There's been past rate filing bills like this that haven't gone anywhere, but maybe with the implementation of the Affordable Care Act and its emphasis on rate filings and reviews, this bill will gain some traction. HB 1907 by Island is another bill that would basically allow the Public Insurance Council to review rate filings on request of the TDI Commissioner. And finally, we have HB 287 by Zedler, which allows, after a completion of an independent review of a disputed medical billing claim, the party who sought that review is entitled to the name and professional qualifications of any doctor or healthcare professional used to perform the review. This basically ensures that the appropriate professional is reviewing medical claims at the independent review stage. So, for instance, if you have a child's mental health need, that a child psychiatrist, psychologist is reviewing the claim as opposed to a foot doctor.